everyone, my name is Laura Prater. I'm very excited for the opportunity to present this project, Firearm Injury and Suicide Prevention in Older Adults, Stakeholder Perspectives on Firearm Retirement. So this is an ongoing project, and it's an administrative supplement from Dr. Emmy Betts's R01 from the National Institutes on Aging on older adult perceptions of driving retirement. And in this specific project, we sought to explore attitudes and values on firearm retirement and ultimately create a tool to aid in planning around giving up firearms. My colleagues and I have no conflicts of interest to report. So the study team is led by PI Dr. Emmy Betts. Also on the team, Evan Polzer, Joe Simonetti, Chris Knopke, and Catherine Nearing. And myself, Laura Prater. I work at the University of Washington in the Firearm Injury and Policy Research Program at Harborview Medical Center. So oftentimes we hear anecdotal stories revolving around older adults with dementia who may become violent and kill a caregiver or a neighbor. So this graph actually shows homicide and suicide death rates per 100,000 by age category. So as you can see, homicide perpetrated by older adults is actually quite rare. And on the right, you can see suicide, which is a form of self-directed violence, which is actually much more common. Also, that's not to say that violence perpetrated by specific groups of older adults, such as those with more advanced cognitive impairment, is not a problem at all. 20% of caregivers to those with dementia reported some form of aggression, and we also know the odds of regression Alzheimer's disease 5 times regression among older adults without Alzheimer's disease. So when we're talking about violence, it's important to talk also about firearms because they're such a lethal method of violence. We know that about 40 to 60% of older adults report having a firearm in the home. And we also know that about 50% of all those who die by suicide use a firearm, and that proportion actually increases to 70% for older adults. So in other words, suicide attempts become much more lethal as we age. So our overall project started with this idea of driving cessation. We know that older adults want time to plan and autonomy around the decision of when to give up the keys. And this particular project was to do the same thing with firearms and learn about what older adults want in terms of planning and what do they value. We really wanted to understand how similar and different firearm retirement is to driving retirement. And we also sought to learn values, attitudes, and preferences of older adults and other stakeholder groups around firearm retirement. And to do this, we did a series of focus groups with older adults, family members, and caregivers, and then key informant interviews with healthcare providers and aging professionals such as social workers and financial planners, as well as members of the firearm industry. So our progress to date, in the older adult focus groups, we've spoken to 28 older adults. In the family member and caregiver focus groups, we've spoken to 5 caregivers. We've spoken to 12 healthcare providers and aging services professionals and 7 members of the firearm industry. So as you can see, this is still an ongoing process. Our analytic process included transcribing our interviews and focus groups. We debriefed in depth during weekly team calls to begin to develop new themes. And we also created a code book based on theoretical underpinnings, as well as our new emerging ideas. So for today's presentation, I'm going to focus on older adults and healthcare providers and aging services professionals, kind of the results from those interviews and focus groups. And for the most part, I'm going to leave out comparisons to driving retirement and focus more on the knowledge, attitudes, and values on firearm ownership and retirement. So here are some demographic characteristics. As you can see in the age range for older adults, about 43% were in the 70 to 74-year-old age category. All of our older adults were white, and about 75% of our providers were white. We're working on recruiting more racial and ethnic diversity in future interviews. This continues to be a challenge in firearms research. So here are some older adult firearm specific characteristics. So we know the average age of initial firearm ownership among our older adults was 22. So a lot of these older adults have had firearms for most of their lives. We also learned that the primary reason for handgun ownership is protection, and the primary reason for long gun ownership is sport shooting. And this really mirrors what we see for younger folks as well. So the initial themes of our healthcare provider and aging services interviews, our first theme was this idea of individual heterogeneity. all older adults are different. And I know we all know that, but they have different values, different politics, different cultures, and they're even from different cohorts. And this came up a lot when talking to geriatricians and other healthcare providers, as well as social workers and aging services professionals. Understanding values around ownership. So older adults own firearms for a variety of different reasons, and understanding that is critically important towards helping them plan. For example, they might own them for sport or hobby. They may own them for protection and feeling safe. They may actually identify as a firearm owner. Sometimes it's a means of social outlet, and also sometimes firearms have family or sentimental value if they've been passed along for generations, for example. Caregiver and family member involvement. So providers definitely said to us that this can be either a barrier or facilitator to firearm planning. For example, if the relationship between caregiver and older adult was fraught, that can definitely make it a barrier. And if that relationship was more supportive, it can definitely be a facilitator towards planning and figuring out an acceptable solution. And then finally, peer-based intervention. We heard a theme of using peers in an intervention. So similar to other health problems, those who have experienced, firearm retirement or firearm transitions may be definitely a superior resource to shepherd other older adults and their peers through this process. So I wanted to talk through a couple of quotes that I thought highlighted some of these themes. This quote on reasons for ownership: guns are associated with power. You have a gun, you're powerful. And you take that away and you're telling someone you're losing power. You're losing your dignity at some level. So this was definitely a common theme of taking guns away, feeling like a loss of dignity and competence in some degree. And then on individual heterogeneity. That heterogeneity is in so many different ways. It's gender, it's race and ethnicity, it's geography, it's sort of the cohort that they were raised and the cultural values around them. So we know everyone is different, and any intervention or tool must allow for these differences and in fact tailor to them. So now I'd like to talk about some key themes from the interviews of older adults, specifically on the concept of firearm retirement. So older adults were generally open to the idea of firearm planning and tools. They definitely agreed that no one should have a firearm beyond the point of what is safe, and beyond the point in which they can be a responsible and safe gun owner. Messaging the term firearm retirement, they thought the term was generally okay, but can perhaps be improved. Substitutions to enable self-sufficiency. So unlike retiring from work or even from driving, there's not as many suitable substitutes when giving up your firearm. So it's really important to understand what the firearm meant to that person. For example, if it made the person feel safe, definitely developing a solution that will help them to feel safe in the absence of their firearm will be critically important. And then finally, this idea of caregiver and family member support came up again. In this context, from older adults, we heard that they needn't expect that they'll have support through their caregivers and family members when making these decisions, and specifically on deciding when it was time to give up their firearms. And I wanted to discuss this quote or highlight this quote on openness to planning. I certainly don't need this arsenal I have now, but I don't know what else to do with it. Keep it safe, keep it out of the hands of some crazy person who is locked up and see what happens. But I inherited most of my guns around, but now I got this big collection of stuff, and most of them are pretty nice guns, but the time will come and they gotta go somewhere else. So this was an older gentleman talking about how he's collected guns over the years and gotten them through a variety of sources. I think it really highlights the willingness to consider planning, but the fact that he really also discusses that there are some complexities, specifically with legal and logistical challenges to removing firearms, particularly when the gun owner has more than one firearm. So some take-home points here. Older adults and healthcare providers and aging services professionals really think that firearm retirement and general planning is very important and worthwhile. We must understand the reasons for ownership and make suitable solutions and a suitable plan to kind of fill that void once the firearm is gone. Also, involvement of caregivers and peers is really crucial for initiating planning and delivering an intervention. And then finally, like most things in geriatrics, putting the person at the center of the decision is critical and really honoring their autonomy and ability to make a decision for themselves. So I did want to mention this, of course, is an interim analysis, and these are the dominant themes, but our analysis is ongoing, and we really look forward to sharing the final results in a paper. Thank you very much. This is Emmy Betts's email address, as well as my email address and your Twitter handles. And thanks so much. I look forward to taking any questions.
Well, hello, everybody. Thanks a lot for joining us. Those were just wonderful plenary papers, and I'm very privileged to be able to host some of the questions from those of you that have been participating in this session today. I'm going to tell you right now, I'm not going to read all the laudatory comments that were made because they were many for the folks that were listening to the presentations. But I will try to handle your questions, and you can continue to enter them in chat if we don't get to yours. We do have to end right on time because we've got another session coming in after this one. So I'm going to start out with Dr. Kosar Dereleglu. We had one question asked to you about whether any of the patients were on ACEs or ARBs, and then someone else answered